Scott did all the work, although I'm one of the co-organizers. My main role is to support Scott. So I'm glad to chair this session, and this session is on public health and disease things, which has always been of interest to me. I'm Jun Liu, a professor of statistics at Harvard, and I'm very glad to introduce our first speaker, Elaine Nsoesie from Boston University, and she is currently assistant professor in the School of Public Health at Boston University. She got her PhD in Virginia Tech some years ago. I'm not exactly sure. She looks very young. Okay, so without further ado, let's welcome the speaker, Elaine.
Thank you. Hi, everyone. I'm going to talk to you today about using non-traditional approaches to public health surveillance. So let's just start off talking about traditional public health surveillance. What does that look like? So usually someone gets sick, and this information gets reported to a public health authority or a healthcare worker. And then there's some kind of laboratory testing to confirm disease. This information gets sent to the Ministry of Health or world bodies if you're talking about an infectious disease outbreak. And this can take a lot of time. And what digital surveillance is trying to do is basically bring together all this information so they're being exchanged at about the same time. So what we do is called digital epidemiology. We look at data from internet sources, mobile phones, and other similar sources to see if we can get information about diseases a lot sooner than public health authorities get, or to get a better picture of how diseases are spreading within communities. And this includes text information, images, videos, sound, location, biological data, etc. So we're not just getting what people are talking about, but we're also getting information about how information flows within networks and how individuals' networks can actually influence their decisions about health. In my research, I've looked at data from several different sources. The first example here is from Baidu. And Baidu is the Google of China. And we got data from Baidu, so what people were searching for, and wanted to look at how that related to influenza in China. We've also looked at data from Yelp. And for Yelp, we looked at what people were reporting after, so if someone goes to a restaurant, they eat something, they think that they got infected at the restaurant, so they'll go to Yelp and they'll write a review about it. And we looked at that data to see if it can be useful for foodborne illness surveillance. We also worked with departments of health, so we mine that information from Yelp, from Twitter, and provide it to them. And then they can use it for either targeted restaurant inspections, so if you have a lot of people saying that they got infected from the same restaurant, they can actually go out and do inspections to see whether the restaurant is okay. Or if you have people talking about similar symptoms about the same time, that can be indicative of an outbreak, and they can use that for outbreak investigation as well. We've used data from OpenTable as well, and the idea for OpenTable, also with data from Digital Globe, was to look at how we can get indicators of social disruption that could be indicative of disease. So we looked at restaurant cancellations. So we thought if during the flu season, if suddenly a lot of people got sick with the flu and started canceling their reservations, we could capture that in OpenTable reservation data. And we looked at that for the US and Mexico and found some significant correlations in the data that we're looking at. We've also used data from Flu Near You, which is a crowdsourced disease surveillance website. So people get emails in the mail asking them to fill out a survey every week and to list whether they've had any flu-related symptoms in the past week. UpToDate is a clinician support website. We've also used that for flu surveillance. And then, as you can imagine, I Was Poisoned is about food poisoning. So it's a crowdsourced surveillance website as well, and people go there to write about reports of food poisoning. So if they, again, similar to Yelp, if they eat at a restaurant, they think that they got infected at a restaurant, they would write about it on I Was Poisoned. I'm going to talk a little bit about some of the work we've done using data from Amazon, but this is just examples of some of the tools that we've used for public health surveillance. Also, if you have questions at any point, feel free to ask. So a study that we published 2 weeks ago focused on Amazon product reviews and how we could use that for monitoring unsafe food products. So this is the paper if you're interested in checking it out. And the idea behind this paper is that when food goes through a lot of steps before it gets to your table, right? So from production to processing to distribution, whether it goes through a restaurant or whether it goes to a retail outlet or ends up in a restaurant and ends up on your table. However it gets to your table, there are many, many opportunities for food to get contaminated, either with pathogens or with chemicals or other toxins. And when we look at social media data, what we see is that people will eat, let's say someone eats, they get sick, instead of going to a doctor, they will tweet about it. And so when you look at Yelp data, you get really detailed information where someone is actually experiencing symptoms and they're writing about it because they're very angry. So we wanted to see how this data can be useful for public health. So the reason why this is a useful or could be a useful data source for looking at unsafe food products is because it takes a lot of time before product recalls are issued by the FDA or companies. So this is an example of a salmonella outbreak in Washington State, I believe. And the outbreak started over here, and it took about 4 months before a recall was issued for that particular product. And all the while, people are getting sick, so the outbreak has already gone through its cycle and is basically dying down by the time the product was actually recalled. And there are many reasons for that, one of them being that there has to be a very thorough investigation before the FDA can issue a recall, but companies also have the opportunity to issue recalls. So a simplified recall process looks like this. Consumers issue a complaint, or a lab is, so people go in to inspect a lab and they find that there are issues with the lab, or other complaints coming through other channels. And then this goes through an agency which then monitors the reports and looks at whether there's an outbreak going on in the community, and they make sure that they collect as much data as possible. So the FDA has to do a very thorough investigation, something that would hold up in court. So if the company decides to sue them, they can actually defend themselves. And then at some point, the product is recalled either by the FDA or by the company itself. So there are two reasons for product recalls. The first is people are eating it and they're getting sick because the product was infected or it's past its expiration date or for other reasons. So this example is the kind of data that you will look for. So someone said they ate something, they had food poisoning from a Chinese restaurant. This is another example, someone also talking about food poisoning. This is another example. People are usually threatening to sue. I'm not sure they actually sue, but a lot of the data has people threatening to sue for different reasons. This is another example, this time from Whole Foods, where someone is waiting for an apology. So this is one of the reasons why a product would be recalled. People are eating it and they're saying that they're getting sick. Another reason is mislabeling. So this is an example from Amazon where a product was produced on shared equipment, and it actually does note that on the product label, but it didn't say on the Amazon website, so this customer was very annoyed by that. It's another example again. This one, it contained lemon, but it was not listed as an ingredient on the product. So someone who has allergies could consume something like this and have a really severe allergic reaction to it. So for this project, we got two data sets. We had data from the FDA telling us when products were recalled and information about those products that were recalled. And then we also got data from Amazon giving us reviews, customer reviews for various products. And the goal was to bring these two data sources together. So you would think that's very easy, but in data science, that's usually not the case. So we have what is called a universal product code. So that's attached to every single product that we're getting from every product in the market. And you get that when an FDA issues a recall in their information, you should have the UPC number. And that's a 12-digit code. And then we also have Amazon Standard Identification Number, or ASIN. So if we can just get the Amazon number, put it through an API, we should be able to get the universal product code, and then we can match those two. But this is what the FDA data looks like. It's kind of difficult to tell what exactly is the UPC in these blob of text. And that's what we needed to figure out. So there's several different numbers. So our first step was to extract all those numbers. Next step is to match those numbers to a particular product or a particular company. So we know every single manufacturer has the first 6 digits are unique. So this is a unique code. So we attach that to all the different UPC numbers that we got, and then drop whatever numbers are remaining, pass this through an API to get the product information and then go back and see if that actually matches the product that has been recalled. So we had to do this for all the products in our database. And at the end, we end up with a database that links these two different data sources together, and this is publicly available for anyone interested and can be accessed and used for research. So we have 1.2 million reviews. So these are reviews of Amazon products for grocery and gourmet food products. Of all those reviews, only 5,000 of them are actually for recalled products. So that's a very small number. So products get recalled, but not as often as we would think. But when it happens, you see it in the news and people talk about it. So we started to develop a classifier, and we're trying to see what are the features that would be predictive if we had to build a classification system. We thought about volume of reviews over time, like how has that changed? That wasn't very useful because if you look at recalled and non-recalled products, they've both increased over time. And if you look at individual products, also for most products, the reviews tend to increase over time. Another thing we wanted to look at was how people rate products. Could the ratings be useful? Again, the distribution is quite similar, so even if a product is recalled, it tends to still have pretty good reviews. And the reason why the ratings tend to be high is because you don't recall, when a product is recalled, it's not the entire product that's recalled, it's just a batch of the product that's recalled. So you can have 3 different people packaging the product, but one person is infected and gets the products infected. The other batches could be okay. We also looked at volume of reviews for these different products. So this is the list of recalled products in our database, include everything from Alfredo to baby food. We looked at whether volume of review could be useful for predictions. That also was not very, very useful in our classification system. But what was useful was reasons for recall. So if we look at FDA's reasons for recall, which are listed right here, we could take this information, build a word set. So we basically build a group of terms that are associated with recalls, and then we can use that to parse our data and identify reviews that are relevant and can be used in building our classifier. So that's what we did. Sampled 6,000 reviews, and then manually annotated them. So we had 3 different labelers, and they had to annotate them into these 4 different groups. So the first class was to label the review, whether it was actually about someone falling sick or having an allergic reaction, or the product expired, or whether it does not imply that the product was unsafe or cannot be categorized. So reviews that fell into the non-categorized, the reviews that could not be categorized were excluded from data, and then we ended up using the other 3 classes. We combined the first 2 classes, so we had products that were unsafe in those 2 groups, and then the third were for products that were considered safe. We tried a bunch of classification methods, as you can see. Most of them performed pretty similarly if you look at the F1 scores. The best performing method was the BIRD method over here, and that was introduced by Google last year, and it's basically a language model, and it's been shown to perform pretty well compared to other standard approaches. And one of the reasons we found out why our methods did not perform or performed very similarly and had a really hard time differentiating between those reviews is because the sentence structures were very similar. So if we looked at the distribution of safe and unsafe foods, looking at it, basically comparing what people were saying and how similar or different they were for the safe versus unsafe foods products, they're actually very similar. So that's one of the major challenges in this classification process. Our implications for this study, currently we're talking to the FDA to see how we can go ahead and actually do this prospectively and not just retrospectively. And this is very important because unsafe foods are not just a problem in the US, they're a global problem. So if we can actually develop systems where we can do identification a lot sooner, then we can take actions faster and limit how many people get affected by those products. And one other thing to note is that in our data, we actually identified additional 20,000 reviews that contain the keywords that we're looking for, but were not associated with unsafe food products or recalled products, which could indicate that this data could be useful for just telling the FDA or others that further investigation is needed. The second study I'll talk about is using social media for behavior risk factors surveillance. We also published a paper on this recently looking at physical activity. So we all know that there are lots of people on social media. Most people are 49, most social media users are 49 years of age or younger. And this data can provide us information about the built environment, but also about people's interactions, access to different resources, likes, dislikes, etc. This is just an example. I usually use the slides for people who have never used Twitter or want to know what Twitter looks like. But the main idea here is that there's information that we can extract from Twitter, and there's also information that is explicitly stated. So things like someone's Twitter handle or time zone, you can get that because it's explicitly stated. But you can also infer things like gender or race or occupation based on information that people provide on social media sites. So for this particular study and other studies for this project, we wanted to see how we can develop measures of different health indicators in communities. So we wanted to know how people are talking about whether it's exercise or what kinds of foods people are consuming or how people talk about alcohol use. Physical activity is very important. We know that insufficient physical activity is a risk factor for many chronic conditions, including heart disease, and it has been associated with loss of life and has a very significant global economic cost. And the WHO and member states are trying to reduce physical inactivity across the world for each nation by 10% by 2025. There's already quite a lot of tools that people are using to collect data on physical activity. So this include wearable devices, but also apps on mobile phones. But one thing that we think social media offers is that in addition to looking at the activities that people are engaging in, we can also get sentiment around activities. So how do people feel about different physical activities? And could this inform us about physical activity prevalence in communities? We can also get data at scale, so we can get larger data sets compared to maybe wearables where people actually have to buy, but social media is technically free for most people. We can also track changes over time. So how are people talking about physical activity over time, and how does this correlate with the prevalence of physical inactivity in communities? But one challenge is that there's no demographics. And if you look at many studies that have been done in digital epidemiology, the data tends to be aggregated across demographic groups, which is an issue because there can be very significant differences across demographic groups. And so we wanted to see if we can infer gender by looking at people's social media information. So this is just an example of the kinds of, we use social media and we reveal a lot about ourselves. And this is an example of the kind of information that people reveal. So if you share your location, you might be telling people about where you live. Or if you share what kinds of events you're engaged in, you can tell people about your income. So, and the reason why we need to know gender for this particular study, we know that there are several issues around privacy. And we did aggregate this data across the different populations that we're studying. But the reasons why this was important is because of differences in risk factors, especially physical activity. Also, if you look at different age groups, different people talk differently on social media, and so that information can lead to different estimations as well. Just to push in this point on why it's important for disaggregating this data is you can get visibility of small and hard to reach populations. So people that, if you aggregate the data, basically get lost in the crowd, you can actually identify those communities in your data. You can also identify other factors that interact with specific demographic attributes such as ethnicity, and you can identify gaps in your data. So what parts of the country do we have no coverage or little coverage? And if we want to design interventions, it can be more effective because you target specific groups instead of targeting the entire population. So we built a machine learning classification system that takes people's names and infer the gender from that. The first method basically just matched information to Social Security data. So we got a list of names based on Social Security data and did the matching for that. The second and third methods did linguistic processing of names and then try to infer gender from that. And so this used random forest and support vector machine classification systems. And then we brought all of those together to get one classifier for each individual in our data set. So our data consisted of 1.3 million geotagged tweets. We had about 481,000 users, about 57% men and 43% classified as women. And this was for 2,900 counties in the US. So we can break this across for different regions in the US and make comparisons, but the take-home message is everyone talks about walking across all the regions in the US, but when you start looking at gender differences, men tend to talk more about more intense physical activity than women. In most cases, when we looked at gym-based activities, men talked a lot about CrossFit, while women talk a lot more about yoga. And this is important because intensity in physical activity is very important when you're thinking about risk factors for cardiovascular diseases. And so it's been shown from CDC data that women tend not to meet recommendations for physical activity a lot more when compared to men. So this is just showing you what I just said by region. So we look at calories burned for an average American adult, and we can see that for some regions there's more similarity, while for other regions we have a little bit more difference across the two groups. So when we also wanted to look at how this data compared to data from the CDC, first of all, we didn't have data from the CDC for that time period, which is another reason why we thought this study was important. CDC data for that particular region was available, for that particular time period was available from 2013. And we're doing this study, the data we had was from 2015 to 2016. So we didn't really have something to compare to. And so what we did was we forecasted physical inactivity in the US based on the CDC data that we had, and then develop our models and see how well our models could estimate physical activity in the US by combining Twitter data, but also with demographic data and both environment variables such as safety, neighborhood safety, which it impacts whether someone is going to go out and exercise or not. So if your neighborhood is not safe, you're less likely to go out and exercise. And as you can see, what we found was that putting these variables together can give us pretty good estimates of physical activity for all the different regions and also for males and females separately. So we're pushing to see if these data sources could be used for estimating these health quantities in the absence of CDC data. So while we're waiting for CDC data to come, we can be using this to at least think about what's going on in neighborhoods. So some of the potential implications is just looking at what people are talking about and then using that as a way to talk about physical activity with healthcare providers. Like healthcare providers can look at our results and maybe talk to your patients about what's happening in your specific region and how to help them meet physical activity recommendations. The last study I'll talk about is on using satellite imagery and also and obesity prevalence. So I've been talking a lot about food and physical activity for this talk. So for this particular study, which we published last year, we used deep learning to examine the association between the built environment and neighborhood obesity prevalence, neighborhood adult obesity prevalence. Obesity is a major global health problem. It affects more than 60 million adults worldwide. In the US, about 1/3 of adults are obese. And in the US, the last readings we have from 2017 listed 46 of 50 states to have an obesity prevalence of 25% or more. So it's a very significant problem, and it's a risk factor for many other diseases. Obesity is also a very complex issue. It's been linked to many different health factors and environmental factors, and this including genetics, early life influences, so kids who are obese tend to be obese as adults, unhealthy diets, lack of exercise, too little sleep, environmental influences, and we wanted to focus on environmental influences. And there's already been work looking at this. So there's been studies that have shown that things like having sidewalks in the neighborhood would encourage people to go out and exercise, or having green spaces like parks encourage people to exercise. But what we found is that different studies come up with different conclusions because they use different ways of measuring the built environment. So you can have one study that looks at the presence of fast food restaurants, but the way they define fast food restaurants or how they count that is different from another study, and they end up with different conclusions. So which of them is actually right? And so the idea for this study is to see if we could come up with one method that could be used across different regions to assess obesity prevalence and look at how these risk factors could contribute to obesity. So we looked at data from 6 cities, Memphis, Tennessee, Seattle, Bellevue, Tacoma in Washington, San Antonio in Texas, and Los Angeles. So the numbers you see over there are basically rankings in terms of obesity. So California would be the 47th most obese state in the US, while Texas is the 8th most obese state in the US. We also got estimates of obesity prevalence from the CDC for validation. We looked at points of interest data as another data source. We looked at per capita income because we know that income is linked very significantly to obesity, so poor neighborhoods tend to have higher obesity prevalence. And then we got satellite images from Google to build our built environment indicator. So we had about 150,000 recent satellite images from Google, and this is what our images would look like. So this is just one example. These are 2 other examples showing you how the environment looks like. We used a transfer learning approach, so we got a model that had already been trained on ImageNet data. The model had already been trained using millions of images from ImageNet, and then we retrained that network using the satellite images that we have, extracted what we call the future vector, and then used that in a predictive model. And then our points of interest data was a very comprehensive list, so we went between looking at just focusing on health-related indicators, so like food and exercise, versus looking at everything more comprehensively. And we decided to go with a more comprehensive list instead of just looking at grocery stores, for example. So if we just looked at obesity and poverty, we saw very significant correlations. So if you look at, as I mentioned, neighborhoods that have more poverty tend to have higher obesity prevalence, while neighborhoods with higher income tend to have lower obesity prevalence. And this is important because one of the critiques that we got from our study is that we were probably just capturing socioeconomic indicators. But if we use the same data to estimate the socioeconomic indicators, so specifically income, our models did a lot less better. So the performance was not as good as when we're estimating obesity prevalence. And so our assumption is that we're capturing a lot more than socioeconomic indicators in the images that we're looking at. So these are the results that we had from our regression models. So we have, on one side, we have estimates using both environment variables, so at the top, while at the bottom, we have points of interest data. And we just wanted to compare to see, if we just looked at density of restaurants and fast food places and parks, was that sufficient enough for us to estimate obesity? It does give us some pretty good estimates, but looking at the images tended to give us a lot better estimates than just looking at the number of fast food restaurants, for example. So looking at this visually, this is what the actual data would look like from the CDC, and then this is what we were estimating in our models. What we saw, we found that for places where we overestimated obesity prevalence, we would look at the images, and the images will have very little greenery and would not have sidewalks or other things that you might think would be associated with obesity prevalence, but those tended to be higher income neighborhoods. So even though people might not have things around them that encourage them to go out to exercise, they can actually afford to go to a gym. This is another example for Los Angeles, California, so similar results. And then you can look at the images to compare for high obesity census tracts versus low obesity census tracts. Most of them were very significantly different. Memphis, Tennessee, so that's the obesity distribution. And then, yeah, we have higher obesity census tracts and lower obesity census tracts. And the main conclusions from our study is that we could use these methods to compare obesity prevalence across different neighborhoods. If we wanted to build an indicator of the built environment, this could be a way to start thinking about that. How do we use methods like this to build a more comprehensive indicator of a neighborhood and then compare that to other neighborhoods in other cities? So a couple other things that I wanted to mention before I run out of time is that while I think there's a lot of potential in using these data sources for health research, there are also many limitations that are important for us to think about, or issues that we should always be thinking about. And three of those issues are around regulation for this data, representation, and data linking. So for the first topic is around ethical use of social media data. There's been a lot of conversations around this, and people have come up with rules. But we still have a lot of studies that we do in this space that is not ethical. It's IRB approved, but it's not ethical. So IRB was not really developed for the kinds of research that we're doing right now. IRB aims to protect research subjects from the potential harm caused by the research methods. But when we develop big data systems, we're not just affecting the people that are captured in our data, we're going a lot beyond that. And this is very important when we think about sensitive topics like mental health. So if you're estimating people's mental health status using your social media data, what are the potential impacts on those individuals? How can people misuse that data, for example? Another topic is the question of who is in your data. We talked a little bit about this before. Already I talked a little bit about this in the African context, but it also matters in the US as well. So let's think about an individual called Angelina, who is 45 years old, has 3 jobs, does not have health insurance, so they're probably not going to be captured in your electronic or medical record data. Or if they're captured, your record is very spotty. They don't have time for social media use because they're so busy, so they're not going to be captured in social media systems. So if you think of an entire community of people who have similar indicators, they're probably not going to be captured in these data sources, right? So when we develop systems where we're comparing data from these 2 sources, we might have correlations between those systems, but exactly what is not being captured in that data. So one study looked at, by Scapino and colleagues, looked at 3 data sources. So they had traditional ILI data from, so that's influenza-like illness data from a traditional surveillance system they had, and so that's usually people going to doctors and that information collected. And then you have biosense data, which is electronic health record data, and Google Flu Trends data. And what they found was that when they tried to make predictions at the zip code level, higher income zip codes had the best predictions. Lower income zip codes or poorer zip codes had the worst predictions, independent of what data source you looked at. And we can think about these biases being captured at every single step of this data because the data set is not produced specifically for health purposes, and so we're not always thinking about what are the demographics of people that are being represented in this data set. We've also done a similar study looking at Yelp data where we wanted to see if data from Yelp actually represented people would tend to have the most exposure to foodborne illnesses. So there's been studies showing that lower income communities would tend to have higher foodborne illness prevalence. But when we looked at this data, we saw that the reports that we were getting were mostly coming from counties where you have individuals of higher income, have a bachelor's degree. So it's not necessarily from the neighborhoods that are the most affected, or counties are the most affected by foodborne illness. So this just shows you that on a correlation matrix. But to show you this visually, so this is poverty in Georgia, and then this is Yelp data in Georgia, and you can see that there's very little to no data in those counties that have the highest poverty rates in Georgia. And one reason why people are not captured in this data is not always because people are not using these platforms. We know there are lots of people using social media platforms, but the things that people discuss on these platforms are not necessarily the things that we're interested in studying when we study health outcomes. So they might not be captured in our data for those reasons. As we use this data to build systems, so my concern is that we will build systems that only benefit people who have higher income and are able to or have the time to use these platforms and feel more free to share the kinds of health information that we're looking for. And so it's important for us to think, how do we use this data and how can we create systems that capture not just those in higher income brackets, but also those in lower socioeconomic brackets. One last thing I wanted to mention was just the potential risk for linking this data. There's already conversations around this, and different people trying to combine social media data with health data. And there's a lot of use to it. But again, back to the point of representation, there are communities that are not going to be captured in this data. They're not going to be represented in the way that we think they should be represented in this data. So it's always something to think about. Does this data set capture the individuals that we're thinking that it should capture? And if we combine these two data sources, are we going to exacerbate existing health inequalities by using these different data sources? And even some of the tools that we think are working perfectly might not be working. I don't think this has been completely verified for Fitbit yet, but this was an article that I was reading recently saying that it's possible that these wearables are not accurately tracking heart rates for people of color. So some suggestions are really important, even though they weren't built specifically for big data. At least they're a starting point for us to start thinking about ethics when we develop our studies. But it's important for us individually to go beyond that and think about how to develop diversity within our data, but also within our research teams, and also working with communities that we're trying to help. If we're designing studies for specific communities, actually reaching out to those communities and working with those communities. And be transparent about our research, our goals, our methods, and our limitations, of course. Lots of people contributed to the things that I've mentioned here. Some of them here in Boston, some in other states. And thank you so much for your time. Oh, the cube, yeah.
This one? Oh, catch it.
I think, does it work? So you did mention a lot of risks that I was thinking about a lot of risks from linking the data and from very selection, like the selection bias in the data. And to what extent do you think that we are getting causal information and causal finding from big data and from this data rather than just correlations? Because if we actually learn something causal, that may be still worth it. If it's correlational with hugely biased data by selection, then we are doing potentially a lot of harm without, not so much benefit.
Yeah, so most of the studies I have seen have been around correlations, so looking at observational data and trying to see whether it correlates with some official data source. But there's also use of this data to develop tools to serve communities. So an example is the study I talked about where we looked at foodborne illness surveillance or foodborne illness reporting. So we mine that data and provide it to health departments, and then they use it to do restaurant inspections or outbreaks surveillance. So if those individuals are not being captured in that data, then they're not going to be receiving services from the health department.
I actually have a related question. Say insurance companies, as I imagine, they would be interested in this kind of methods. Probably they already use it. Out of the box, they don't care about causation, only about correlation. Yeah. So it's still important. That's my point. Yeah. Well, if insurance companies are not making wrong decisions, then at least they are not going bankrupt. I mean, just the usual economic argument. I mean, you want them to be efficient, right? To do their business efficient, if they're properly regulated.
Yeah, precisely. Yeah. So I mean, your goal may be efficiency, but in the process, they end up leaving people that might need their service or discriminate against particular groups of people.
But that has nothing to do with causality.
No.